Good afternoon, and thank you for the very kind introduction. I'm personally very excited about this conversation, and we were able to have a pre-call and then spent the last hour and a half or so together. Feathers were flying, we had lots of fun, and I think that you'll hopefully agree with me at the end of this that we're going to try to invent something here that we probably don't know yet at the beginning. It's going to be very provocative, and we really want to try to wrestle with the topic of engagement. You know, probably my favorite engagement, observation is, you probably heard the old joke of, the daughter comes to her father and says she's engaged, and his first comment is, "Oh, really? How much does he make?" So she says, "Oh, you men are all alike. It's funny. How much does he make?" He asked the same question about you. So engagement, I guess, is in the eye of the beholder and has lots of different definitions. We've been trying to wrestle with trying to define it. And the idea of this panel, really, we're hoping, is to look at three central questions. First, what is engagement? It seems like maybe it's the faddish term of the day. It used to be patient-centered care. Hula hoops was before that. So what is engagement, and what's going to be the next fad? And is it a fad, and is it real? We want to wrestle with that. A second question is, can you measure it? Whatever it is it really possible to measure it? Is it dark art, or is it possible to measure it? And finally, why does it matter at all? So with those as kind of a backdrop, I feel very honored to have the group we have today. And I'm just going to say a couple of words that I've learned about each, and then ask as a first round for each of our panelists to say a little more about themselves for a few minutes, and maybe an opening idea or two on the topic. And then I'm going to try to keep things lively. I've been asked to be in a Charlie Rose fashion, so I'll emulate Charlie as best I can. But I'm going to start, actually, David, with you. David's actually our outlier on the panel, as he pointed out. First thing he said to us is, "I'm a journalist, so I don't belong here." And I said, well, actually, maybe why don't we position you as the smart common man? So David is actually the ultra-smart common man, as you'll see. He's an author, a journalist, a provocateur, and something you may not know about him, he actually, out of college, bicycled around the world, 13,000 miles, and wrote his first book about that, first of many books. So David can tell us a little bit about that, hopefully. Joanne is CEO of Axial Exchange, and a fascinating company that perhaps she'll tell us a bit about, was also the CEO of Red Hat. So she's an experienced entrepreneur. But the thing that we may not know about her, she said, is that she was one of the first female traders on the Chicago Mercantile Exchange. And she promises not to yell as much as she did in those days, but she has a lot of fascinating opinions. So we'll hear some of those from her. Susan Frampton is PhD, president of PlaneTree, which, as many of you know, is really one of the leading companies that have been actually founding ideas in the whole arena of patient engagement and patient engagement. But something you may not know about her is she actually, her first love is apparently medical anthropology and forensic anthropology, and she has a bone collection in her dining room. So if she ever invites you to dinner, make sure you know that first and are up for it. I'm sure you will be. So, and finally, Lisa Gualtieri is an assistant professor at Tufts University School of Medicine, and has actually a background in IT, but has a series of very novel courses that she's developed and teaches at Tufts. And what you may not know about her is she actually has a passion for swing dancing. So if at any point the panel does not meet your expectations, you want us to go into the previous group's gig, then maybe we'll bring them back out, and Lisa can lead us. So with that, I wanted to start, if I could, Joanne, with you, and ask you to say a few words about, a few more words about yourself, but also kind of some opening thoughts about the idea of engagement. Can it be measured, and does it matter?
Sure. Well, Thanks, everybody. I'm delighted to be here. I'm Joanne Rohde. I'm the CEO and founder of Axial Exchange. And we are in the patient engagement business. And we decided that before it became a buzzword. And so it is such a buzzword that we've often thought about changing what we do, or changing what we're doing. But essentially what we believe is that we are only going to bend the cost-value curve in this country if patients get more involved in their own health and can share that in a meaningful way with their healthcare providers. And I started this company really on the back of my own personal experience. As Jeff mentioned, I had a big job and was used to going 24/7 and found myself getting sicker and sicker and sicker, and went through 10 different doctors before I finally got diagnosed, and began to realize my mother had had a similar experience, my brother had had a similar experience, that the ability to communicate with our care providers meaningful information was flawed. The ability to take care of ourselves, because our physicians had a lot of the information we needed, was flawed. The ability for me to have consistent knowledge was flawed. And so we created our company to try and address those problems at scale in a situation where the healthcare providers win, the patients win, and the plans win, and that's what we've been doing.
Great. David?
So I'm David Ewing, Duncan, and thank you all for having me here, and Jeff for those interesting words. I am a bit of a ringer here. I'm not a scientist, I'm not a physician. I do hang out with a lot of scientists and physicians as a science writer and health writer. And I think the perspective that I would like to bring here is what I'm mostly reporting on and thinking about these days, which is the role of technology and how it's affecting issues like patient engagement. Although I'd like to expand the sort of way we're thinking about this just a little bit, and we had a vigorous discussion about this earlier, and I'm sure we will again here. I think of more people engagement and patient engagement being a subset of that, because it's really critical that, especially with some of the rising technologies, some of which you're seeing here at the meeting, we're having the ability now to measure people, to predict in some cases what may come down the pike for people before they show symptoms or get sick. And I think this whole idea of engaging our society with health is really an urgent and important consideration here. And so it's a continuum. I mean, obviously, patient engagement, as Joanna said, is absolutely crucial, and there are a whole lot of problems around that. But I would like to think of it as a continuum, trying to keep people as healthy as possible by engaging them more effectively.
Good afternoon.
Susan.
My name is Susan Frampton, and I'm the president of PlaneTree. And PlaneTree is an interesting organization. I didn't found it. It was actually founded by a patient about 36 years ago. It was the very first patient-centered, patient-founded organization in the country. And the good news is many of the ideas and innovations and disruptions that PlaneTree first espoused back in the 70s have finally hit the mainstream. And I would say that's also the bad news, that it's taken that long for that to happen and that we still have a great deal of work to do. PlaneTree's model has always been a focus on personalizing, humanizing, and demystifying the healthcare experience. And again, I think we're just beginning to hit our stride in addressing those things. And so this conversation, this focus on patient and family engagement, is a welcome topic to explore. And I would just state that I think one of our continuing challenges is that we have not created a healthcare system that engages or is designed to engage patients or families. And we used to say it was a system that was designed really to serve providers. I'm not even sure if providers would agree with that anymore. It is a system that has been designed to serve the system itself. And until we begin to recognize how we move that to a system that supports humans at the level of human need, I think we're going to continue to wrestle with this. So looking forward to that discussion.
Great. Lisa?
Hi, I'm Lisa Gualtieri. I'm on the faculty in Public Health and Community Medicine at Tufts University School of Medicine. And besides the work I do as a faculty member there, I also do research in 2 areas. One of the areas is the use of social media for participant recruitment in clinical trials, and the other is work I'm doing on patient activism. And the patient activism research is what I think is most relevant to the discussion that we're having here today about patient engagement and the really fascinating and fun conversation that we just had in our panel session that Jeff organized so that we could talk about how the panel was going to be run. My starting point looking at patient activism is that I think the whole notion of patient engagement is something that has become almost a marketing term, a buzzword, a way for people to shift responsibility onto patients who may not have the education, the health literacy skills, the knowledge to know what they need to do and how to do it. And in looking at patient activists, people, which I define as people who, because of personal or family health issues, have taken what they've learned and are using it to change policy, to help educate other patients. And in fact, I think we have 2 examples here. I think what Susan said about how PlaneTree got founded was through patient activism. And I think that Joanne was talking about her experience and how her own and her family health experiences led her in this professional direction. So what I'm really interested in patient activism is how do we understand why people become patient activists, what they do in this role, and is there a way to look at reach and impact? And while the ultimate measure is how many lives have been saved, there are many small things such as teaching somebody about about breast self-exam and that leading to early detection, which might save a life. So sometimes it's on very small scales, sometimes it's on very large scales. And I think that this notion of reach and impact is one of the most important ones in looking at this whole broad topic of patient engagement.
Great. So based with that great introduction, I'd like to have us continue and do a round of trying to unravel, maybe deconstruct this term engagement. And suggest we try to get down to call it a 3.0 version of the term. I mean, imagine everyone of us in the audience has different reasons why we're interested in this topic. The 1.0 version of engagement is a notion that there are people who use something called healthcare and somehow are not participating in an active way. A 2.0 version of the term is, hey, that really matters to different stakeholders, because if I'm a health plan and you don't even know I exist or don't participate, it's not likely you're going to sign up next year. And if you're a hospital system and you don't have much of a relationship with me, maybe you'll go to my competitor. So there's a 2.0 version that might be very economically based or industry specific and has to do with a utility that you can get from an economic interaction. So if you'd accept the notion, something like that, of the general arena of what we've been talking, and the first term is something like patient-centeredness, and the second is more like self-centeredness in the guise of patient-centeredness, the question becomes, what really are we talking about? And there have already been some notions that you've each thrown out. It's a continuum, it's relates to a system, not humans, it's a marketing buzzword. Really, we should be talking about things like health literacy. There's reach and impact. So I'd like to go around again, and maybe Lisa, start with you. What is engagement?
Well, I think what it's really meant as is people taking responsibility for their health care, be it being healthy or be it what to do in an illness. So that's how I see it, and I think the reason that I said that before about it turning into a marketing buzzword is because there has been that shifting. And one of the debates that we were having is about illness versus wellness. And obviously, the more that people can focus on prevention, on being healthy, on staying healthy, and clearly that's something that's very difficult for people to do, because everybody knows that it's not healthy to smoke, that it's not healthy to eat too much, and so on and so forth, but we all have trouble integrating that into our daily lives. So I see patient engagement as combining what to do to stay healthy and what to do when you're ill to get better.
Got it. Susan?
So I would say that if we want to keep it really simple, what is engagement? Engagement is emotional involvement and commitment. You know, from the healthcare systems perspective, we want that to be interpreted as patients should care about their own health and wellness. And I think one of the inherent challenges to that is that people spend 99.9% of their lives not thinking about their health and their wellness, but thinking about their work and their family and their friends and all of the day-to-day stuff that all of us focus on. And so when we try to engage with people, I think we need to understand that basic truth, that people are more likely to engage when there is an acute problem right in front of them. And that is a reality that as a system we need to figure out how do we use those teachable moments or those acute episodes to begin to break things down so that engagement can have more of an impact over time. The other aspect of this that I think is fascinating, and if folks are familiar with Rebecca Costa's work, she's an evolutionary biologist, and she said, human beings are designed to react to very acute stimuli right in front of them. So it's what's right in front of you, the fight or the flight kind of response. We're not engineered to think about, 10 years down the road, if I eat too many hamburgers, I might end up with high blood pressure and high cholesterol and then a cardiac event. So I think where we may want to try to intervene is how do we kind of break that up and create more of a sense of urgency around some of those things that really most of us don't interpret as being urgent.
Yeah, I don't even know where to start in some ways. We talked before, and I have lots and lots of discussions on many, many stories about the massive dysfunction of this system. And we had a debate of, before this, and I'm sure we'll talk about it here, what is the role of the patient themselves or the people and their responsibility? What's the role of the system, the physicians, the people that interact at all levels with patients? But I almost think, as a journalist, I used to cover healthcare. I now cover more bioscience. But there's so many things that could be going right. And on an engagement level, at a people-to-people level, we all know what that means in a lot of ways. We engage with our kids, we engage with our friends. You don't have that in medicine most cases. I mean, even at the most fundamental levels where you go in to see your physician, he's looking at his watch because he's got 7 minutes with you or 12 minutes or whatever, the people have dictated. And it's fascinating to me that everybody's unhappy with this. The patients are certainly unhappy, but you look at surveys of physicians, these guys all go in, and I wrote a book on how doctors are trained and spent a lot of time with early stage doctors. Many of them go in very idealistic. They want to help people, even after the rigor of the residency program, a lot of that's squeezed out of them. But many physicians now, somebody had the statistic, but are very unhappy. And on these happiness scales, how do you feel about your job? And it's ranked very low. It used to be ranked among the highest. So I think we need to think about this at both a person-to-person level and at a system level that's really causing this situation. And somebody here said, it's the system feeding the system. And I don't know how we got into this situation, but I think we're very smart people, and there are a lot of smart people involved. And one of the things I like to write about, we're accused in the media of always writing about negative stories, which, in fact, we do a lot. But in fact, there are a lot of positive stories out there, too, and I hope we work that in on the panel here. There are people doing it right and really trying, even entire systems, their hospital systems. My brother had pneumonia recently, and he lives in Maine. They sent him down from Brunswick to the Maine Medical Center. And I was surprised at how wonderful everybody was. It was like a luxury hotel. They'd been trained to be nice. They were courteous. They listened. And I don't know what was going on there because I've been in dozens of hospitals. This is in Maine. And so there are lots of examples where this is being done right, but we all know what this should be. So we need to work on that.
I think that really what patient engagement is, and that buzzword should be expanded as an opportunity to reframe the patient-provider relationship. And what I firmly believe and what we're trying to do in driving a change agent is that the patient and their family ought to have more knowledge, more power, and more information about their illness. And it is unrealistic, whether it was a 7-minute appointment or even a 30-minute appointment, that a professional caregiver is going to know everything that you know about yourself. When in the middle of the night you feel badly, when your glucose dropped. That's not realistic. But what I think where we are able to see the convergence of sort of consumer technology and healthcare is that with the rapidly falling cost of communication and all the wearables, there is actually simple ways for patients to learn about their disease, to monitor they and their family's symptoms, and to be able to come in and make sure that that time is usable. And then conversely, there is the opportunity for caregivers, instead of trying to do the impossible, spend 7 to 15 minutes, you know, taking somebody with 4 comorbidities and figure out how they are, that you can focus that information. And so I think as many problems, we have to stop trying, you know, we can't pay less per procedure. We can't make the doctors any more unhappy. We can't, you know, have a bigger distance between the patient. All those things, if we're going to change an ICD-10 code from 9 to 10, how is that going to improve patient care? It's not. On the other hand, when you're talking about having patient activists, people that break ranks, people that make changes are how things are going to happen. And I think that we actually have the means now as a country, as we move from fee-for-service, and it will take a few years, but we are moving from fee-for-service to some form of value-based payment and capitation. It is the opportunity as a country to fix some of this by getting patients much more actively involved in their own care.
So it seems like perhaps, listening to what you're saying, we're trying to battle 2 problems. The first is a rampant epidemic among all us healthcare thinkers of sort of psychobabble, fuzzy thinking, and not really knowing exactly what we're talking about, and everybody talking about something slightly different, and we're starting to settle in on some different kinds of definitions. And the second problem that I hear you talking about is kind of an implied worldview or business model view that says that engagement has a lot to do with where you sit from a business model standpoint. If you designed a perfect system irrespective of business model, you might say, here's how it would look and this is what engaged people are. And if you're looking at it from the perspective of your own business model, you might have a different definition. So regardless of whether you have those 2 problems. And the reason I say that is, I don't know how many people are health plan executives. I'm going to pick on health plan executives for a minute. How many health plan CEOs do we know who've actually been to their own website in the last 6 months? And it's an interesting question, and yet that's one of the measures of engagement for health plans oftentimes is how many people go to the website. So there's a question I'd like to ask in that context then is, and maybe picking up on something David, you said, maybe we flip it around on the other side. What does the ideal world look like? Tell me what an ideal world looks like where patients are like super duper engaged. I'm going to start, Joanne, with you on your side, if you don't mind.
Well, I'm going to start with a presupposition that there is some form of illness, because I think there is certainly a leading wedge of very well people that plan on staying that way. And that's not really my area of focus or expertise. But as we know, almost everyone in this country, by the time they reach their mid-60s, gets chronically ill. And you know, by the time they're older than in their 70s, there are multiple chronic illnesses. So I think it's a few things. First of all, it's a baseline understanding about what their disease is. And there are some really stunningly bad data about what people actually can retain about in the office, about in the hospital. In the hospital, the patients, even college-educated patients, are only retaining at the 6th grade level. That's because they're doped up and people are coming in and out and they're sick. And so they're only going to hear 11% of what you hear. Even in a regular office visit, that only rises to 25 to 40%. And it's not a realistic assumption that the patient will understand their medical state when they're in the office, or that they can be left on their own to learn it. So there needs to be a way to learn and engage on that. Secondly, understanding how their different symptoms and monitoring work. You know, when do I feel bad? What happened to my glucose? What happens if my heart beats too fast? If I don't take my meds, what happens? What meds am I taking? And so there needs to be simple ways to monitor back to the individual signs about themselves, symptoms, biometrics, et cetera. And then really where I think the role needs to flip over time is that when you see your doctor, instead of saying, and I heard somebody say, what's wrong with me? You ought to be able to be in a more consultancy type of relationship where you're saying, I know that I've got these conditions and I'm supposed to be doing X, Y, Z, but why am I still having this problem? Or what else can I do better? Where the physician becomes, sort of the ultimate super consultant. I think the other piece in my mind is to be less doctor dependent and more care centric dependent. I think that we're a nation of chronic disease, and you don't get well. We used to joke that our tagline ought to be Axial Exchange because no one ever got well in the hospital. But since we sell to hospitals, we can that idea. But that's true. You break fix in the hospital, and you will get well if you're going to get well away from the hospital. And so the people that get you well tend to be physical therapists, social behavioral counsels, nurses. And so in an ideal encounter, there's more interaction with the system, but it doesn't necessarily need to be the doctor as much. So I think that's a way, at least for the sick, expensive part of our country, we can start to shift the equation.
Talk just for a second about incentives. I think, I was talking about the sort of dysfunctional system, and probably if you peel it apart, one of the major flaws in the system is how we incentivize people. And it is based, you start with fee-for-service. It's a system that's based on paying for people who are sick. And, a doctor gets paid when he's a sick patient or takes care of a patient. Hospitals get paid for that. I think we need a fundamental shift of thinking, and this is happening in other parts of the world. It's happening here in places towards a wellness system, and trying to keep people well and incentivizing hospitals, physicians, and others. We have some of these things in place already, but pay for engagement and have models that actually encourage that. I think you would have a lot of what Joanna's talking about with physicians. You would have that happen if the system was a little more geared that way. And I'm sure the experts here can talk about various systems that are in place for that. But I think you need to start with what pays the bills, and how they work each day, what their schedules are. Have a physician that's rewarded for spending more time with a patient and consulting with them and doing things. I've done stories on the power of touch, where studies are done where a doctor will sit on a patient's bed and touch their leg or maybe their shoulder, and spend 2 minutes doing that. And it actually improves outcomes and even the bottom line. These patients tend to get well faster. I mean, again, these are really basic things we already know about, but I think they can be built better into the system.
Some of the points that both Joanne and David made. I think that the aligning of incentives is a really important piece, because at the end of the day, we all have to pay our bills, and so do our healthcare providers. And so some of the hopeful things that I see that are beginning to be piloted are things like DRG codes so that physicians can get reimbursed for having an end-of-life discussion with a terminally ill patient, or codes, payment codes for shared decision-making within an office practice. And for me, one of the lights at the end of the tunnel out there in terms of engagement, true engagement, is something like shared decision-making, where patients are presented with the range of options, where their values and their lifestyles should be taken into account before treatment plans are developed for them. And I want to give you just a really quick little example, because the system doesn't only reward us for doing all sorts of very invasive procedures, it also rewards for doing more screening than anyone on the planet needs. And that's where a huge, huge amount of money is going right now. So I called my dad a couple months ago. He lives in New Jersey, I live in Connecticut, and I said, how you doing, Dad? What's going on? He said, yeah, my urologist just scheduled me for this prostate biopsy, and I don't really think I want to have it done. I said, well, Dad, why were you scheduled for a prostate biopsy? He's almost 81 years old. He said, well, I had an elevated PSA. I said, oh, are you having symptoms? He said, no, I'm fine. I said, so you have no symptoms, but you had a PSA. Yeah, and he said, I've canceled this procedure twice. I feel really bad about it, but I can't talk to the doctor about it. I said, Dad, let me get you some information, because I think it's okay if you don't have the prostate biopsy done, but let me get information for you. And I went on to the Lown Institute and Right Care Weekly, and there's a plethora of sites out there now that you can get good evidence-based information about these things. And I sent him this, and I don't know that he actually read it, but I think it made him feel better that I went out and found some credible information. I said, Dad, look, you actually never should have had that PSA. And by the way, don't allow your doctor to do that anymore. So I think that we are at this really interesting place in time when those kinds of resources are becoming available. It would be wonderful if my 80-year-old father was also, engaged and, had those resources at his fingertips. The reality is he wouldn't use them anyway. But that's where the patient-family engagement comes in. So I think we are going to see a real flip in terms of just that generational difference in how we access information and use it to our own, for our own advocacy.
Building on what Susan was just saying, I think that a lot of it really comes down to health literacy skills and really understanding what not just comprehension and retention of information, but also the cultural underpinnings and the emotional states that people bring to the information that they seek and how they consume it and the decisions that they make as a result of it. So like your example of your father, he was trusting what his physician was saying. A lot of people don't trust what their physicians say, so they can be told what to do and they might be making actually decisions that are not medically sound just because of that lack of trust. And even something like the Choosing Wisely movement, a lot of the patient reactions to this notion of not having unnecessary medical testing, not being overexposed to radiation when it isn't necessary, and so on and so forth. A lot of it comes down to the existing payment system. My insurance covers it, so I'll get it, or why not get it, or the distrust that people feel of the medical system. I'm a big believer in, I'm an educator, but I'm an educator at the graduate school level. I'm a big believer that there needs to be more education at lower levels so that kids are not just learning things like stay away from drugs and watch out for sexual contact that's unprotected, but really understanding more about how to take care of themselves and even things like the importance of sleep.
Fascinating. Okay, so we've now exposed my esteemed colleagues on the panel as a group of revolutionaries at heart. And actually confirming my suspicion that there is a underlying the whole discussion of engagement, there's actually lurking beneath it, there's a pent-up energy to radically, potentially, or certainly very dramatically reform the system, and that a lot of those agendas exist, I think you'd all argue, very rightly so, within that term. So I'd like to make an observation, if that's the case, right? Because each of these things suggest a model of a system that could be quite different than what we have right now. And with all the innovation, we're not necessarily headed very rapidly towards some of the things you said. So this thing I wanted to suggest is, if this is true, there's a pretty yawning gap between where we are now and how people are thinking standardly oftentimes of engagement, and what the implication of some of the things you just mentioned. So I'd like to ask a round of questions about the best way, of course, to fill a gap, because you only can manage what you measure, is to come up with measures that actually measure the kinds of things you're talking about. So I wanted to see if we can live here, over about 5 minutes lightning round, come up with the world's greatest measurement system for what engagement actually ought to be. And I'm going to ask you each to give us 3 measures. And we're going to do that for about 5 minutes, and we're going to open for about 5 minutes of questions from the audience, and then we're going to continue on for 18 hours discussing this afterwards. So I'm going to start, Joanne, with you, if I might, with the 3 best measures of engagement.
So in the eye of the beholder, one of the things that we have to do is to find the value for the healthcare systems. So what does a healthcare system need to measure to know that this is working? And in addition to the thing that the administrators want to measure, which is costs and outcomes as defined by JCAHO, we also suggest there's some other things that measured. So we created the Patient Engagement Index, where we measured healthcare systems on how well they interacted with their patients when they weren't with them. And we basically ranked all 3,000 healthcare institutions. We did this with Becker's. If you go to Becker's website, you can see this. On their ability to share patient information, to make contact with the physicians. And not that it's the end-all to be-all, but we wanted to turn the problem on its head and sort of say, okay, what if all of a sudden the patients were picking based on their ability to have this kind of active relationship? And it's been very interesting to see both the winners who tout it and the losers who threw darts at it. And I won't go into the methodology there, but the other thing that we try and explain to our clients is that we think that self-care and retention are things that you can measure and should measure. And self-care is the ability to show that people are tracking symptoms, biometric tracking, anything that is appropriate for their condition, or trying to figure out where their condition is. Sorry. And and retention is that they will do it for a period longer than 30 days, meaning it actually made a difference and it's somehow changing their behavior. And so we actually do measure this for our clients. We don't really give them a choice. And we give them those reports, and then we show them how they're doing compared to all our other clients and lay out best practices for them. So, I'm sure if I were up here 3 years from now, I would say that there might be something different. But that's where we're starting. And so we're not giving the health institutions really a choice about this. We're measuring for them. Awesome. Thanks. Thank you. David?
Yeah, I'm sitting here trying to think of, there are measurements that the system uses and then personal measurements. But I'm going to go partly with patient or people self-measurements that they establish and that we can work into a system. Patients like me, other websites and entities that track people on things that matter to them. And the patients like me, other organizations like that are actually producing peer-reviewed studies out of that self-tracking data. On the system side, so that would be self-tracking. On the system side, I'm going to go with the obvious ones, but that's why they're obvious. I think you need to be able to measure this in elements of cost and cost savings. That word cost savings in healthcare seems to be almost separate the big gap in between them, but if we can make that happen. And then really where you get down to it, and where we in the US are alarmingly falling off, which is basic outcomes measurements.
Got it. Thanks.
So I'd say there are a couple of measurements at a few different levels when it comes to engagement that I think would be really interesting. I think at a policy level, one measure might be the percentage of patients who sit on each and every one of our national policy making bodies in healthcare. And hopefully it would be at least 50%. I think at an organizational level, one measure might be the degree to which patients and families who serve on patient-family advisory councils feel that they are well prepared, oriented, and trained to be able to affect change within their local care delivery organizations. And I think at an individual level, I'd say shared decision-making, the percentage of patients who have a preference-sensitive condition who are provided decision aids and a decision conversation to help them find the right care plan for themselves.
Great.
Well, Susan took some of my answers, so I always have backups. And I'll say on an individual level, I think that I think it's for all of the tracking devices that we have, I think the most important thing is waking up in the morning pain-free and happy. And no device really tracks that. And I think that that's the most important thing, because if those are both not there, then you need to do something about it. And my third, I'm a big believer in some of the theoretical models that exist. My favorite is trans-theoretical model of change. And I think that most people are firmly at the pre-contemplation stage for many activities that keep them healthy or get them healthy when they're ill. And how helping them, scaffolding them to move along to maintenance would, to me, be one of the strongest measures.
Awesome. All right, there you have it. The world's greatest measure of engagement that's been constructed. So it would actually be fun to try to consolidate that and use it somewhere and see what happens. With your permission, we have time for maybe one or two questions from the audience, and we're fascinated to kind of get how this has landed for you. Yes, gentleman in the center, please.
Thanks for selecting me. I see I'm the only one.
You are the only one.
Thank you all.
At the moment.
It's been spinning my gears, and I wanted to just present something that you've all built for me, but I don't think anyone said it. It started with Jeff's joke. At this point, I don't believe that people get engaged with concepts. Actually, maybe some of us get engaged with concepts. We're engineers, we're biologists, we're doctors, but most people get engaged with other people, right? And they have relationships with other people. They don't get relationship with their health or their diabetes or anything. And I would suggest that maybe, and it's buried in all of our different efforts, is if we promote the relationship, the humanized relationships that are going on, and leverage technology and de-skilled folks within the relationship that we could do, as we're doing in India and other places, we can leverage the relationships to get people engaged with other people and thus engaged with their health. And we basically reframe patient engagement, because that's like the patients in the bubble there, with patient-provider relationship, I think, as Joanne pointed out. So that really just crystallizes a huge opportunity space for me in my work.
Got it. Very interesting. Emphasizing essentially it's an interpersonal interaction, not just a lonely endeavor. Any comments?
Well, I agree that patient to patient is also very important. You're not going to find anybody. I have, as I mentioned, quite a few chronic conditions, and when you meet other people with them, that's all to want to talk about. So finding and sharing like-minded information. I think the one issue today, and one of the things we kind of had to back away from, is that you don't really know anything about the qualification of the people on the other side. And if you get on a lot of these forums, there's a lot of complaining, but there's also, hey, I've got this problem and I got the fever in the middle of the night. What should I do? And somebody will say, you know, drink witch hazel. And so I think the missing piece that we've been trying to figure out is, how do you put patients together and in a way that they can be supportive and share information, but that you're not just letting anybody talk to anybody about anything. Somewhere in there, there's an answer, and we haven't quite cracked that nut yet.
I wanted to kind of touch on your point about human relationships, and I think it's a really important one that we don't overlook. And there's just fascinating body of literature that's emerging that is making those connections to better medical outcomes, better health outcomes, when patients and their families have a trusting relationship with an empathetic, compassionate care provider. And in fact, there was a study I love to quote, found that a physician with a good bedside manner is more powerful in preventing heart attacks than cholesterol-lowering drugs or aspirin taken on a daily basis. So there's a power to relationship, and I think it's like the 800-pound gorilla in the room that nobody wants to talk about. Is we have a system that's really denigrated the relationship aspect of care, because at the end of the day, we're talking about human beings caring for other human beings, and we don't value that.
Well, that might be a wonderful note to start to wrap up on. I see that we have other comments, and I so want to acknowledge you, and I'm sure we could continue for a long time. I also know that our conference organizers, I'm getting stared down because we have 53 seconds. So I did want to start to wrap up, and very much actually to just acknowledge the four of you. It's just a delight, to hear from you and to participate in this, and all of your attention has been wrapped and highly appreciated as well. I learned a tremendous amount. I think the idea, Susan, you're saying that we may be able to hopefully over time inject a humanity into the system through our thoughtfulness and courage, and I appreciate your courage to go on this journey, and really to try to be thoughtful, because how we define terms is going to in the end make a big difference as to what we try to do. I think as Einstein said, if he had an hour to try to solve a problem, he'd spend the first 59 minutes trying to come up with the right question. And I think the right question is really what is the term we're thinking about, and that will drive hopefully some real thoughtful redesign in our next iteration of the system. I wanted to thank all you. I just also wanted to mention that we at least, forgive, it's not meant to be a plug, but one of the things we're interested in our organization is we're building a kind of innovators network of people who are interested in kind of thoughtful ideas and pushing forward the industry to the next level. Just out in Silicon Valley, and there's a ton of big data people who are excited about this, and there's people around the country. So if you're interested in being part of something like that, it's just forming. It's kind of like a homebrew club of innovation of the industry. So feel free to let me know, and also obviously to talk to any of the panelists afterwards. Thank you again very much to all of you, and thank you for your attention.